All right, so with brain tumors, again, anything that increases intracranial pressure can have the patient show up with those same signs and symptoms. Once we do the diagnostic tests, that's when we're going to get our confirmation or information. And not so many options: surgery, radiation, chemotherapy, not so many options. But again, designer drugs, they're on the way. Doing biopsies of some of these tumors and having special chemotherapy or special immunological type drugs created for specific tumors, that's all on the front now. Neurological medications for tumors, it's very amazing. I don't understand all of it, but they're able to create designer drugs specifically for tumor cells that are unique and such. Well, some of you might get involved in that. All right, seizure disorders. For most patients, a seizure disorder is the result of some other neurological problem and is not primary. If it is a primary disorder, they call it status epilepticus, okay, or epilepsy. That is a seizure disorder. That is a seizure disorder. Most of the other seizures that occur are because of something else, like the patient has a stroke, so they have an irritable area of their brain because it's become damaged and swollen, and they have a seizure. The patient has a brain tumor, which is pushing on neurological tissue, causing swelling and damage, and so they have a seizure. The patient has a high temperature, and so they have a seizure. Most of the time, seizures are the result of something else. If not, then we call it epilepsy or status epilepticus. In those patients, they will seek to find the irritable area in the brain and try to ablate it. Ablate means freeze or fry, basically destroy the irritable area in order to stop the seizures. Why will they choose to do that in a patient with status epilepticus? They'll stop having seizures and they won't have to live the rest of their life on anti-seizure medications. You don't want to be on anti-seizure medications if you don't have to. The main side effects are sleepiness, drowsiness, inability to keep attention, difficulty with coordinated movements. You're not supposed to take anti-seizure medications and drive. So, if you can find the irritable area and ablate it, seizures go away in a status epilepticus patient, and they don't have to be on lots of anti-seizure medications for the rest of their life. All right? So most of them are related to something else that's happening. That's just the big definition. Caused by a spontaneous, uncontrolled, transitory neuronal discharge from the cerebral cortex. You got an area that's popping off, it's being bad. If you can find it and ablate it, that's better than having to be on medications for the rest of your life. Right, my older son had a karate instructor he was 18, he was wonderful, but he had status epilepticus. And they were trying very hard to find the area that he was having seizures from so they could ablate it. Because he was on so much meds. Sometimes he would just be like, not there. And that's not good in a karate instructor, you know. They need to be at least with it, but I don't know. I remember he came to class and he had had a seizure like the day before. He wasn't doing very well. He knew the seizure was coming, so he was able to protect himself, but he bit his tongue. He had this huge hematoma on his tongue, so I felt really bad for him. He's a great guy. So again, if it's status epilepticus, they'll seek to ablate it. If it's a seizure caused from something else, they'll try to cure whatever else is going on. Or if they can't, then the patient is going to be on Dilantin, Tegretol, phenobarbital. They're going to be on some medication. And I talked about the side effects. They're not wonderful. Everybody has a certain threshold for seizures. That means I might seizure easier than you do. Or you might seizure really, really easy. So we have to identify in patients what that is so that we don't over-medicate them. Those who have the lowest threshold seizure the easiest. Remember, there are many different things that can cause patients to seizure. Alcohol, definitely. Withdrawals, DTs can cause people to seizure. So many different things. We look for that first before we ever assume status epilepticus or epilepsy. It's usually from something else. All right, rule out your treatable cause for diagnosis. Doing some of the diagnostic tests as we talked about, looking for a cause. Treatment, Ablation would be nice if that can do it, or medications. We will talk about in pharmacology tomorrow some of the different neurological medications. Be sure that you are aware of Dilantin or phenytoin. You need to know those lab values, 10 to 20 for your boards. If you're taking LPN boards or RN boards, Dilantin is a testable therapeutic drug level. It's the most common anti-seizure medication. Okay? Airway. If your patient's seizures, how do we take care of them? Number one, airway. Okay? We need to make sure that things stay safe for this patient, and that has to do with seizure precautions that the doctors order. What do we do in the hospital to protect the patient during a seizure? Seizure precautions. What do seizure precautions mean? Padded side rails. Side rails up. Suction at the bedside. Turning them on their side. That's what we do if they have a seizure. Okay, let's talk about that now. If the patient's having a seizure, what are your responsibilities? Make sure their airway's open, turn them on their side, loosen their clothing, and get somebody to bring some drugs. You don't want them to seizure any longer than they have to. It is a huge metabolic event if somebody's seizuring. Do this for yourself for like 10 or 15 seconds. It's like a workout, right? That's how it is for a patient too. It uses up a lot of blood sugar. It tenses up all their muscles. If we let them seizure too long, they will have a cardiopulmonary arrest. That's why we want to give them medication right away. Ativan or Valium, IM or IV, immediately to stop the seizure. What that does is it breaks the muscle response to the neurological discharge in the brain. It doesn't necessarily stop the seizuring here, right? Valium does help decrease the brain. But what we're trying to do is stop the muscle response so that we don't have this rapid use of sugar and so forth. Does that make sense? We're looking for... Yes, you time it. And you try to find out from the patient, did they know it was coming? Did they have a smell or an aura? Did they have any sort of experience? And then sometimes we have patients that come to the hospital and fake them. Those are the patients that end up in one of the centers downtown on the camera with continuous EEG monitoring. And they're like, I'm doing it again, can you see it on the camera? I hope you're getting a picture of the, you know, and during the seizure, they're coming in and out. If they're faking it, guess what happens with their brain waves? On the continuous EEG, their brain waves stay the same. If a patient isn't faking it, during those times of seizure where they're having these contortions and strange looking things, we're going to see changes in their brain waves. So that's one of the ways that we can diagnose. And yes, there's a fair number of people that come in faking seizures. Why? They want a week off work. Now, there are other things that help us know if a patient's faking or not. And I'm talking with the tonic-clonic, the rock and roll seizure. All right? When a patient's having a tonic-clonic seizure, when the seizure breaks, they're going to go into what's called a postictal phase. ICTAL, postictal phase. It's a deep sleep. I'm going to show you, and I'm not, it's my own fault I'm committing this to film. But this is what happens, all right? The patient rocks and rolls, and then they go into a postictal phase. Their head will drop, and they go like this. Has anybody seen a seizure? Have you seen that? That is exactly what happens. It's a deep sleep. They're very flaccid. And what's impaired? Their airways, because everything is relaxed. The seizure is completely broke. They're exhausted. And there's something else that happened that I didn't demonstrate for you, and you're going to be so glad. The patients lose control of bowel and bladder. And a patient who's faking a seizure doesn't usually do that. Not usually. And sometimes they don't have a bowel evacuation, but they usually always wet themselves. Okay, so that's that pearl where you can tell the doctor's like, oh, that patient didn't have a seizure. Like, they had a postictal phase and they urinated all over themselves. And the doctor will go, So that's a pearl. that's something for you to know that can help confirm that yes, indeed, a seizure did happen. So yes, you're glad I didn't demonstrate that for you. But the postictal phase is classic after a tonic-clonic seizure. Confirm that with loss of bowel and bladder, and you've most likely got something that's true. Most patients won't fake urinating all over themselves. They must really want the week off bad for that. That would be amazing. All right, status epilepticus is the term that we use for the patient that's seizuring nonstop, that is at risk of going into cardiopulmonary arrest because of extensive muscle movement, use up of all the blood sugar, extensive metabolic demand. And so this particular patient needs medication right away. We talked about it, Valium, Ativan. If you're an LPN, you want it IM. Or IV, right? If you're the one who has the patient for the day, you want to be sure that you have medication that you can give right away, in an area that you can stabilize to stop the seizure, IM. If you get patients admitted with seizures and you don't have the emergency medication, you need to ask for it. Some of you went through that in simulation, didn't you? Some of you had that scenario in simulation. All right, dementias. How many of you have taken care of a patient with dementia? How would you describe dementia? Ha 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 ha.
A return to childhood.
Return to childhood. That's probably a good way to describe it. So their cognitive functions are deteriorated or limited, or not real bright and sharp like you would expect. The one type of dementia that we have to be careful about labeling patients with is Alzheimer's disease. Once a patient has a diagnosis of Alzheimer's disease, it's very difficult to place them in any place but an Alzheimer's facility. So one caution, for you, your families, and so forth, is that we don't really want to label somebody as a Alzheimer's dementia patient until we're fairly sure about that. It could be part of the aging process. It could be related to other disease processes. There are a lot of challenges that occur with the dementia patients. Some of them are pleasantly confused in the nursing homes. A lot of them are placed. And I had one patient when I was a CNA. Her name was Fanny. Her name was Fanny, and she would walk the whole unit all day long, saving. She would take off all of the leaves of all of the plants, alive or silk. And she would have them in her pockets, and we would find them in her bed. At the end of my shift, I would have to go get all the leaves, the silk ones, and go put them back on the tree. And then the next day, saving. And she was taking all those leaves and putting it every day. After a while, believe me, they weren't buying new alive plants, right? She'd killed everything. All right. I don't know if she had Alzheimer's, but she was definitely with dementia, and she was pleasantly confused. We were able to manage her. What becomes difficult is when the patients with dementia start to wander. We had another patient in the long-term care facility who was always waiting for the bus. She would go up to the front, and she would sit on the bench by the front office, and she would have her purse, she would have her coat on, and she would sit there. My bus is coming. My bus is coming. She would sit there all day long. But the bad thing is, once in a while, she would get up and try to get on the bus. So one day they found her out down the road on the freeway ramp. The police brought her back to us. She said she's looking for her bus. We're like, yeah, we know that. She got pretty far away. Usually the neighbors would bring her back, okay? But this time she got down to the freeway ramp looking for her bus. So taking care of the dementia patients as they progress can be a big issue of safety. Making sure that, because they don't a lot of times know who they are or where they are. Have you heard those reports on the news where they find somebody out in the middle of the desert, or they're like looking for this person? They're looking for this person and they don't know where they are, and they maybe have some dementia or other issues. Okay, so Alzheimer's disease is one form of dementia. And we're learning a lot about that right now. There's a lot of research that's going on. Part of what we know is there's amyloid protein deposits that occur in the brain. My understanding is at this point we still can't 100% accurately diagnose Alzheimer's disease without Without a biopsy, yeah. And most of the times they can confirm it after death. But it wouldn't be like doing a brain biopsy would be a smart thing to do. That would be more risk than benefit. They also noticed that the patient has a decrease in acetylcholine in the brain. So they can give them medications which improve their function. If they give them medications which improve acetylcholine, which is a neurotransmitter in the brain, then they can hold their memory a little bit longer. It doesn't stop the progression of the disease, however. This shows you a picture of a normal brain and what happens with the brain as Alzheimer's progresses, and this is a cross-section, so it shows you how it really deteriorates. And basically connections aren't made. Yeah, it kind of shows there. Some of the stages that the patients go through, and this is the joke, we're all Alzheimer's patients because of the forgetfulness and everything, and progresses to confusion, and then the patient who walks around and they don't know who they are, where they are, and then the end stage, which is so very hard for families, that the family member no longer recognizes their loved one. This is very, very hard. And if they go to an Alzheimer's unit, know that those patients have special armbands, and there's door alarms all over the place. They're like in locked units. The best care model for them is they do the same thing every day. Same thing every day. Make sure they're protected with their armbands. And now, the special units just for Alzheimer's patients. What happened with liability? When I was a CNA too, if that person gets away, gets down on the freeway, gets hit and killed, we're responsible for that patient's safety. And so that's why the standard of care and the quality of care for Alzheimer's patients had to change. Because in the basic long-term care facilities, you can't provide the protection necessary. They're going to wander off. All right, so what we want to do before we give an Alzheimer's diagnosis is rule out all the other things that could possibly cause dementia. Seizure disorders, depression, bleeds, deficiencies, HIV, all those other things. We will give medications which tend to increase acetylcholine, and I don't know. I read somewhere there's possibly a vaccine that's being developed. I don't quite get that and how that would work, but that's in the works.